And to get it perfected, basically we had to change our echo machine. And so, oh, well, that's only $276,000. And then we had to send our tech to Houston to Dr. Bonchi's. And we had 3 echo machines meet her there. 2 of them were already there, and then one was brought in by Philips, another was brought in by BASAL, and we tested all 3 against each other. And then we had a tech involved in the training, Dr. Bonchi's involved in the training, and then someone who does post-processing involved in training. And then we were trained by Dr. Marwick online in Tasmania, who is sort of the father of strain imaging as I see it. And then we did strain on every patient we had for 4 years. And now it's coming back to sort of roost for us and lay some eggs. And it's really giving us some new perspective on coronary artery disease. And I'm so glad we stuck at it. We were registered to be part of the SUCCAR study, which is a study of ladies, for the most part, with breast cancer getting possible cardiotoxic chemotherapy. And of that group, strain echo is part of the research where some patients are treated with the information provided on strain echo and some patients are treated without the information. And that's about 18 studies around the country, around the world actually, and a blinded study. So we hope to get some results from that. But let me give you Dr. Koch and his presentation, and feel free to ask questions as we go along. Thank you. Dr. Koch.
Get situated. So hello everyone, can you hear me?
Yes.
Okay. So like you said, I'm Nick Koch. I'm a third-year general cardiology fellow over at Northside Hospital in St. Pete. We're going to be talking about kind of strain today, kind of maybe not a newer modality, but kind of one that's emerging clinically in use, and one that some people may not be as familiar with. Let's see if this works. So happy post-election day. Hopefully we're kind of over it and can move on. But the whole, issue with strain comes about where, a lot of times we want to evaluate LV function. As we know, LV systolic function has a lot of prognostic indications. Yeah, I started the recording. Okay. So LV function has a lot of prognostic implications if there's dysfunction. And so we have a number of ways we can assess function. A lot of us, reading echoes, we kind of do this eyeball subjective method. And certainly, there's some validity to it. Certainly as you get more experienced, we're looking at the endocardial movement, wall thickening in each segment to assess for a global LV systolic function. There's also somewhat semi-quantification methods. We're looking at wall motion, and we kind of grade these wall motion segments on the scale. And certainly we have more objective and quantitative methods with Simpson's, biplane methods where we can get a kind of a quantitative evaluation of the LV systolic function. The problem is that's that gross ejection fraction. Sometimes we may have subclinical systolic dysfunction with preserved EF. So technically the ejection fraction by every measure is normal, but there is systolic dysfunction, and that does play a role, as we're finding out with, prognostically, where even if they have a preserved EF, technically systolic function is not normal, and in a lot of disease states these people have worse outcomes. So a little background on, when we talk about strain imaging, we have to talk about the actual technical, how are we measuring it? A lot of this principle is based on Doppler color flow, kind of first elucidated back in 1842 by Christian Doppler, where we're measuring blood flow velocity based on this Doppler effect. And a lot of you are probably familiar with the Doppler effect. It's basically a change in frequency as structures are going towards or away from the probe here. So basically, if we have a transducer probe here, we're sending out ultrasound signals that are bouncing off red blood cells that are bouncing back to this transducer, and this frequency shift we can calculate and get a velocity of blood flow. One limitation, as we'll see with some of these methods, is this angle of incidence, where ideally if we're perfectly in line with this blood flow, this angle is 0 and it doesn't affect the measurement. But as we go to 90, obviously the cosine, it's 0 and it kind of cancels out. So we want to minimize this angle to get a true velocity. In some of these methods, that plays a big role. So we have kind of two forms of Doppler echo. We have pulsed wave Doppler and continuous wave Doppler. Again, pulsed wave Doppler sends out kind of one beam it waits for it to return, and we kind of get localization along the path of where that signal is. As opposed to continuous wave, you got two crystals continuously transmitting, and you're getting every signal that bounces back along this beam shows up as a signal. And they each have their limitations and benefits. So tissue Doppler approach, we're making use of this Doppler principle to get a velocity of the myocardial structure itself. So typically, if we're doing Doppler, we think about it as looking at the red blood cells in blood. These red blood cells have a high velocity, a lower signal intensity, but now we're more interested in the velocity of the myocardial itself. So, if we kind of put a filter in here, we're looking for myocardial tissue that has a lower velocity overall, but maybe a higher amplitude. And we can filter this out, and we can get a velocity of the myocardial tissue itself. So tissue Doppler imaging, one of the modalities that can be used to look at strain, as we'll talk about, where it records motion of the myocardial tissue itself, which has velocities much lower than that of blood. So, typically blood velocity, can be higher than 20 centimeters per second up to 800. The myocardial tissue, generally velocities of less than 30 centimeters per second, so we can filter out these higher blood one and just focus on the myocardial velocities. And a lot of times we use kind of a modified pulse wave to record these low velocities and reject the higher blood flow ones. But as we see, there's a lot of issues with this that come up. So tissue-derived Doppler is one method we can use to derive strain imaging. We'll talk about some of the clinical utilities of it, and when we're going to use it and when we're not going to use it. So again, here an example of tissue Doppler imaging. We're looking at the velocity of the myocardial wall itself, and one of the downsides to this particular method is we have a lot of it's angle dependent. So we have two frames here. One, we have a wide kind of beam here where we're looking at this kind of lateral mitral annulus. And if our beam's coming from here, this angle of incidence is pretty high. We're going to get a lot of error in this measurement. So if we're going to do this method, there's a lot of technical things that your techs have to do to kind of narrow the angle sector here, and we want the beam as perfectly aligned with the structure as we can. And again, an example of what we get with tissue Doppler imaging, where everyone's seen these. We use it a lot for diastolic function. We're looking at just the velocity of the tissue itself during systole and diastole. So the main thing is, what are some of the errors or problems with tissue Doppler? We have translational motion, where if you imagine this whole wall is moving up and down. If you have an infarcted segment of myocardium here that's not moving, we want to kind of pick that area out. But if we put a beam here, the normal wall segments here can tether this infarcted segment, and if we see this infarcted segment that may be moving or may have velocity, even though it's not moving itself or thickening, it's being tethered from the good segment to the myocardium. And so we kind of get maybe falsely elevated velocities in this segment here, as well as the Doppler angle we talked about, and translational motion. Just the act of breathing itself imparts some movement to the myocardium that shows up as tissue velocity here. So we may not get a true measure of the function of that myocardial segment. So that brings us to strain imaging. What is strain? Well, think about strain as a deformation. So if we have some sort of tissue, here we have like a myocyte. Strain is we're looking at thickening or deformation of the myocardial tissue itself. We'll see some terms thrown around: strain and strain rate. Strain itself, think about it as just it's a dimensionless quantity. It really represents the change in dimension over a length. And it's really a measure at its simplest form, a measure of a contractile function of an individual kind of myocyte or myocardial segment. As we know, the heart is not a 2D structure, it's 3D, and it has a very complicated systolic function where it kind of moves and thickens in 3 different planes. And so we think about kind of an X, Y, and Z axis. These translate into longitudinal, circumferential, and transmural movement of the heart. So another review: as a muscle shortens, really in the circumferential and longitudinal direction, the heart shortens and thickens in the radial direction. So by convention, if we look back at the formula here, this is our starting length, this is our length when it deforms. This way, longitudinal, this is going to be a negative number. So by convention, when the muscle shortens in longitudinal or circumferential direction, we have a negative strain. And in the radial direction, the heart thickens during systole, and that's by convention a positive strain. It can get somewhat confusing because a lot of these are negative numbers. You know, the ASC kind of recommends we refer to strain as either decreased strain or increased strain. So for the LV, we're going to have 3 strain values: longitudinal, circumferential, and radial or transverse strain. And we can use these to describe kind of LV function in these 3 dimensions. Again, just a kind of a graphic here of during systole, the heart shortens from longitudinally, so we get a negative strain. Radially, it thickens, so again, we have a positive strain. And circumferential, we have a negative strain because this diameter kind of decreases. And just a graphic of longitudinal, you know, short axis here of what we're measuring. And this is really what we're measuring with strain. We're measuring the deformation, or kind of this change in length over time, as well as the rate of change over time. So strain, again, we have tissue Doppler imaging here. We take a kind of a segment for analysis that we know the length of it, and we can kind of measure the strain. So this is just the shortening of the myocardial tissue itself. If we plug this into an equation that the echo machine does, we integrate it, we get strain rate. It's just a change in velocity integrated over all these times. And down here, radially, it's a positive strain because it's thickening. If we integrate all these, you know, changes in length over time, we get a strain rate. Strain rate, very similar. So instead of the length now, this is a velocity. So if we take a velocity at one part of the septum here, velocity at the other part of the septum here, we know the distance. We kind of measure the change in velocity here, we get a strain rate. And so strain rate is related to strain. I have a graphic here. You know, if we measure kind of the strain rate or velocity of the myocardial tissue itself, we integrate all these over time, we get strain. You know, if we integrate it over a distance, we get velocity. So, you know, all these things are related: displacement of tissue, strain rate, velocity. You know, we can calculate each one of these from one and the other. And just a graphic example here, you know, at its very simplest, we have tissue velocity. Everyone's familiar with this in regards to diastolic dysfunction, where we got a pure velocity of this segment of the myocardial tissue itself. You know, displacement, we can measure the movement of the myocardial tissue, so similar to TAPSE for right heart dysfunction. We're just strictly worried about measurement of the movement of the tissue here. Then we look at strain and strain rate. We're looking at either strain, the change in length over time, or strain rate, the rate of change over time. So all these are related either by the derivation or integration of all these values. Skip through some of these. So we have, you know, this is an example of a recording of a strain rate. So we have the software packages, and they're all different. It has a sample volume here, and it measures the velocities of the different segments here, and it integrates it over time, and we get a measurement of the strain rate. And they all have different normals. This is from an ASC document from 2004, attempting to, you know, describe a normal strain rate of individual segments. And this is from the most recent guideline from a journal of the ASC in 2015 on chamber quantification, where they talked about normal strain values from recent publications and meta-analysis. And the point here is a lot of these software packages they have slightly different methods in calculating this. And so you may get slightly different measurements depending on the software package you use. In general, strain rates of over or greater than -20, or less than -20, I should say, are pretty normal, but they all have slightly different mean and standard deviations. So, you know, again, one of the recommendations if you're gonna start doing this is to measure strain on the same software package if you're going to follow patients up serially. So how do we get these images? So again, we talked about there's different methods. One is tissue Doppler method, and then we'll talk about kind of the newer SPECKLE tracking method. So tissue Doppler, as we talked about, we're just looking at kind of the velocity of the myocardial signal itself, of the myocardial tissue. The older method, we do get high frame rates, but it's, again, angle dependent. The most common strain that we use in clinical practice, or at least that's been studied, is longitudinal strain. The most common used strain of LV systolic function. As you know, there's also circumferential and radial strain. You know, if you're getting images, technical aspects, you want to minimize frame rate, minimize force shortening of the apex. And we use the 3 standard apical views. So we use the 4-chamber, the 2-chamber, the long axis view. So we see all the myocardial wall segments. The newer method we'll show a lot of examples from is 4D imaging, where it's kind of real-time 3D, where we get all these segments at once. And there are some advantages to that, where we measure kind of strain in one heartbeat, as opposed to these, where if you're moving from the 4-chamber to 2-chamber, you're not measuring the same exact heartbeat, and it may have beat-to-beat differences, especially a patient with AFib or arrhythmias. Again, we mentioned if you're going to do serial strain measurements to follow up on a patient, it should be done using the same vendor and software. So what is speckle tracking? So back to kind of the ultrasound signal itself. Whenever we send out an ultrasound beam, we do get interference patterns, we do get reflections, scattering, interference from all kind of the tissue interface here. And a lot of times this interface pattern is constant on a certain myocardial segment on a short period of time. And what speckle tracking is, it's making use of this interference pattern to kind of tag that area of the cell and watch it move over time. So typically these are about segments of 20 to 40 pixels, and the machine will tag these and track these over time, beat to beat. It's really kind of an angle independent method, so now we're not sending an ultrasound beam down to measure tissue velocity. We're looking at the interference pattern, which is a lot less dependent on the angle of incidence as opposed to tissue Doppler. And again, here we look at different segments of the myocardium, and each of these has a different kind of interference, fingerprint or speckle pattern that we're measuring. Again, we talked about the heart. Not only does it move longitudinally, circumferentially, and radial shorten, but it also has a twist. So the basal segments kind of rotate clockwise, while the apical segments rotate counterclockwise. So if you imagine kind of wringing out a towel, it's kind of how the heart squeezes during systole. And we can actually kind of measure this. So if we look at cardiac rotation in a normal person, if we're looking at the apex here, we have counterclockwise rotation where now the strain pattern is positive, but in the same heart, if we look at more the base, and we're looking at speckle tracking, looking at the twist of the base of the heart, it's negative here. So these have opposite twists in a normal, healthy segment. Then we can kind of measure this. If we look at the basal and apical rotation here, again, this is kind of, the analogy of if you're holding on to the towel and wringing it in opposite directions, that's what we're seeing here. We're seeing kind of the apex will rotate one direction, the basal segments will rotate another direction, and we can calculate kind of a total torsion of the heart. Example here, and why is this important? Well, we do have different twist dynamics and different pathologies. Again, the LV is a complex structure, and it's kind of simplified it to think about just one measure of EF or one measure of systolic function in some disease state. So here's kind of a graph in one of the ASC documents where you can look through certain disease states. You may either have no change in twist, or you may have kind of an increase or decrease in twist, such as aortic stenosis. You may have decrease in LV twist, but the untwisting. And you can measure all these parameters. Is there delay in untwisting? Is there delay in time to peak twisting? So speckle tracking, this is kind of what we end up with. This is an example of using kind of 2D images. Here's the peristernal long axis. We have the anterior septum, kind of the infralateral posterior wall. And the machine, the computer, most times automatically tags these wall segments, the basal, mid, and apical segments, and it color codes them and lays them out on this is a flat kind of graph here, where we start the basal inferior lateral wall, going down the apex into the basal anterior septum wall. And again, remember, in this, we're worrying more about kind of global strain, longitudinal strain. We're worried about negative numbers here. So kind of negative 18 to 20, depending on what study you look at, is pretty normal strain. And we look, here's the QRS complex or systole. We have pretty normal strain pattern here where all the segments are thickening with high negative strain and then during diastole. This is an example of a newer kind of 4D method. A lot of times what they utilize here is we're getting all these segments in one heartbeat. So again, this is using the 4D probe. We have the apical 4-chamber, 2-chamber, and long axis in one cardiac cycle. And this is a real-time structure, so we can move and interrogate all these walls at the same time and get around some of the limitations with measuring different beats. So Doppler strain versus speckle tracking. This is from a 2011 cardiovascular imaging article. They talk about kind of the caveats and advantages of each one. You know, Doppler technique here, again, high temporal resolution, well validated. It's less affected by translational motion than other methods as opposed to speckle tracking. Again, it's been validated independent of the angle here, so this is a big advantage of we get around this angle dependence of some of the tissue Doppler methods. So how do we use this clinically? Well, you know, the clinical uses are increasing. Again, this is a measure of regional and global systolic and diastolic function, and it has correlated well with kind of what was previously possibly one of the standards, tagged MRI strain scanning. You know, if we think about back to the ischemic cascade, where, you know, if you remember that kind of graph, you know, by the time we get to visual wall motion abnormalities or a drop in EF, we're well down that ischemic cascade. So our goal is to kind of, you know, look for dysfunction earlier on in the cascade when there's metabolic issues, when there's issues with diastolic function, or subtle issues with myocardial systolic function before we get a drop in EF. So kind of the goal here is we want to look for early stages of ischemia, as well as you know, maybe subclinical cardiomyopathies that may not have manifested itself with a drop in EF. So the, you know, strain may be more sensitive to identifying ischemic segments during stress echo, you know, looking for dysfunction during chemotherapy, as well as the role in cardiomyopathies that we'll show some examples of. So example of this is a patient with a kind of a look at apical lateral infarct. So here's more kind of a transmural apical late guided lymph enhancement with a scar area, as well as subendocardial ischemia kind of in the lateral wall. If we correlate this with strain imaging, you know, the green and purple segments here are the areas where there's a full transmural scar. And if we look at the strain imaging here, these areas have less strain as opposed to normal basal segments here. Same thing here, if we focus on, now instead of looking at the whole heart, we're looking at the apical segment here. As we get more towards the transmural area, you can see we get less and less strain. You know, for further away from the normal segment, we get normal negative strain. As we get more to this transmural infarcted area, we get less negative strain. So it does correlate pretty well with infarcts seen on MRI and kind of regional wall motion. We can also use it to look for ischemic segments. There are some strain features that show up that you can look for during ischemic dysfunction, even if you have a normal EF. Some of those are, you know, systolic lengthening. So again, by convention, here's QRS1 beat. This is end diastole. Then we get start of systole and aortic valve closure. So during systole, you know, normally, remember, you get a good normal negative strain, and then it relaxes. Well, if you have segments that are ischemic, you may have systolic lengthening. You may have post-systolic shortening here. So after the aortic valve closes, you may see some shortening of the ischemic segments here, as well as less strain overall. So all these things you're going to look for on strain imaging to maybe identify some subclinical ischemia that you may pick up on before there's kind of a global drop in EF or kind of a visual wall motion abnormality. So for cardiomyopathies, an example, amyloidosis, we can look for abnormal strain, can be seen in amyloid involvement, even if you have normal LV thickness. And this does have prognostic implications. So an example here, you know, this is a nice normal strain, all these nice high negative numbers, as opposed to amyloid, where, you know, typically you may not always see this, but kind of you may have a distinctive pattern of preserved apical shortening, but the basilar segments have decreased strain. Again, a patient with hypertrophic cardiomyopathy, if you're looking more, sorry for the image quality, but more the basal segments identified by the blue line here, as opposed to more the apical segments. These have nice normal strain. You get less strain in this basal segment here. And again, a lot of times we know, you know, we look for the classical thickening of this basal septum, but in some patients, certainly patients who have a family history of it, if you're screening family members, they may not have significant thickness, but they may have abnormal strain indicative of an underlying cardiomyopathy before it's manifests itself clinically. Another thing, you know, it may help in identifying patients with hypertrophic cardiomyopathy versus the athlete's heart. As you know, a lot of these athletes, you know, the athletic heart, we can have a lot of the same LV geometry changes, increase in size, thickness. But if you were to do strain on athlete's heart, Certainly much more normal than a decreased strain in a hypertrophic cardiomyopathy patient. So a strain may help differentiate, abnormal function or, kind of a pathology in patients that even though they may have similarly thickened hearts. We can also use it for RV function analysis. So again, typically when we look at RV function, a lot of the times it's kind of very subjective. We do have some simple measures of RV function, TAPSE, tissue Doppler. We're looking at just, kind of the translational motion of the RV wall. These are both prone to translational error. Even if you have RV dysfunction, the LV can kind of pull it along, and so these may be normal. But we can do the same parameters. This is the kind of the Mayo format where the right is on the left. But we can do strain of the RV wall, again, and look for less negative strain indicative of dysfunction. Not as well studied. This is from the ASC document. They kind of mentioned abnormal is, again, less than -20. And again, kind of just overview of uses of strain, certainly for coronary disease, may be useful in adding to dobutamine stress echo, not just looking at wall function, but looking at changes in strain. Certainly infarct, looking for remodeling, infarct size, and reperfusion. So detection of coronary disease, even if you have segments that are normal kinetic, they have shown that longitudinal strains have been shown to be abnormal in patients who have normal kinetic segments supplied by a significant stenosis. So again, back to that issue, we want a modality that can maybe identify a significant ischemic segment before we kind of get the wall motion abnormality. They did look at one prospective study where patients who exercised, after exercise, they saw that strain in the kind of a basal anterior segment 1 hour after exercise remained depressed even when velocity and wall motion was normal, and this may be indicative of kind of subclinical myocardial stunning that you may not see just looking at wall motion or EF. Again, longitudinal strains, they're reduced in patients with MIs and correlate with infarct size and EF on MRI. And in one study, longitudinal strain displayed a 85% sensitivity and specificity for detection of infarct to involve segments using strain and strain rate cutoffs of -13. Viability, again, stunned myocardium displays reduced strain, and that may improve with dobutamine infusion. So again, this may be a modality we can add to viability studies, not just looking at EF and wall motion augmentation, but looking at improvement of strain values. So there's been some recent studies that looked at strain. This is from JACC Imaging, just published in August. This looked at prognostic implications of strain in asymptomatic patients with hypertensive disease. So this is a prospective study. They looked at 388 asymptomatic patients, non-ischemic, who had hypertension and abnormal LV geometry, LVH, LV increased LV chamber sizes, either concentric or eccentric LVH on baseline echo. And so all these asymptomatic patients with the hypertension, they underwent a baseline echo. A few patients we'll talk about had a repeat echo 1 year after, but they looked at the longitudinal strain and the circumferential strain measured using SPECKLE tracking. And really they wanted to look for, do patients with abnormal strain, otherwise asymptomatic, do they have worse outcome over time or more cardiac events? So they found in 19% of patients they had major adverse cardiac events, and these events were associated with a higher prevalence of concentric hypertrophy and impaired longitudinal strain. Just a breakdown of the events here, 12 heart failure admissions, acute MI, as well as strokes. They also found that in patients who had initially normal strain, a subset of those patients went on to have a repeat echo with deterioration of the strain. And even this deterioration of strain was associated with adverse events in asymptomatic hypertensive heart disease. And they did with fancy statistics, they found that this longitudinal strain was independent of any other clinical or objective measures. And it had some incremental prognostic findings. So they found that adverse events were significantly associated with age, higher heart rate, lower systolic blood pressure, higher prevalence of AFib, higher use of beta blocker, prevalence of concentric hypertrophy, higher PA pressures, as well as highlighted here, greater impairment of diastolic function and longitudinal strain. And this is really independent of all these other factors. So, they had a couple clinical echo models here. The one that the findings that were significant systolic blood pressure, AFib, and longitudinal strain. And what they also came up with was sort of a risk score. They wanted to look for, could they calculate a risk score that may predict events? And so all these measures here had independent association with the events. So a score of greater than 3 had, not the best sensitivity, a better specificity for major adverse cardiac events, but if the score is over 3, they had a pretty good sensitivity for future heart failure events. So you can see here, if you have an elderly patient over 70, maybe they don't have AFib, they don't have significant LVH, but now they have abnormal strain, and they define it as less or greater than negative 16%. Just those two alone, that puts that patient at higher risk for heart failure admissions down the road over, in this case, about 4 years. So again, they had incremental prognostic implications as opposed, on top of all the other clinical factors that we, in everyday practice know that increases adverse outcomes. Let's skip that. Well, this is on viability. So again, a non-viable segment, infarcted segment, it's not going to, change its rate or deform, as opposed to viable segment where we, we do have strain in that segment. And this is a study that looked at, compared to PET viability imaging. This was sensitivity and specificity with dobutamine echo, where, again, not terrific in the 60%. If you add strain imaging to that, you increase your sensitivity specificity here, where if you have a non-viable segment, that doesn't change. If it's dobutamine stimulation, you have increase in the strain rates in the strain. Chemotherapy-related dysfunction, another modality, pathology we can use this modality in. This is an article from 2015, kind of review of chemotherapy-related dysfunction and how we, may evaluate for it. The ASC and the European Society, they kind of came out with, kind of a simple little diagram of how do you kind of follow up on these patients. So certainly, we're looking at EF. If there's a drop in EF, we kind of have diagnosed cardiac cancer-related cardiac dysfunction from the therapies. But even, what do we do with patients who don't have a drop in EF? A lot of people are looking at, can we look at strain? If the strain doesn't drop in baseline, you may have no evidence of subclinical dysfunction. However, if we get a drop in the strain over time, you probably have subclinical LV dysfunction. Then the question is, do these patients benefit from putting on cardioprotective meds, even if they have a normal EF? So we'll kind of transition to a few clinical cases we've had here. This is a 55-year-old male being evaluated for hypertension. Again, we do 3D or kind of 4D speckle tracking here. So again, this is our real-time 3D images we have. We get all the 3 apical windows here. The machine puts them into a 4D image, and it kind of tags this wall segments here. And then we get measures of strain. So in this case, we have a pretty normal strain pattern. All the segments are, line up pretty well. They're all synchronous. We have high negative strain rates into the high teens and 20s here. And again, we can also look at it on this flat model, or we can kind of get a polar map, which we're used to looking at a lot of different modalities, where we have the apical cap, the apical, mid, and basilar segments here with the anterior, inferior, lateral, and septal walls. And again, we map all these segments here, and we kind of come up with a global strain number. In this case, this is a pretty normal study. Another patient, again, kind of middle-aged male with hypertension. If we look at his 2D images, obviously the ejection fraction here on the apical peristernal long axis, and the short axis, again, normal EF, certainly does have LVH here, but normal systolic function by any other measure. Again, we have the 3D images. Now we look at strain, and we have marked reduced strain in multiple segments. So the apex, kind of the apical segments may be a little preserved, but certainly mid-wall segments, or the mid segments and the basal segments, marked reduce in strain. So again, we have 2 similar patients, both on antihypertensives, relatively controlled hypertension, but now may have some data where this patient has subclinical LV dysfunction, and that may have some prognostic implications down the road. Again, another case here, we have kind of these basal segments here. We have marked reduced strain as opposed to some of the other segments. Another case, this is a 90-year-old female. She has a known history of coronary artery disease, prior stenting, clinical CHF in the past with known ischemic cardiomyopathy, also sniffing at valvular disease, as well as ventricular arrhythmias, and she has a dual atrial ventricular ICD pacemaker with kind of demand pacing at times. So again, our 2D images, right off the bat, we have a reduced ejection fraction, probably at least moderately reduced. Basilar segments contracting well, but we have kind of a large area of apical akinesis seen here, here, and here. Consistent with prior echoes, consistent with her history of prior infarct and ischemic cardiomyopathy. So again, if we do strain, in her case, we had to do kind of separate 2D images. But again, on strain images here, we look for this apical segment here to have less negative strain values, and actually in some cases positive strain values. So these are indicative of more, kind of instead of shortening, lengthening, and dyskinetic segments. So again, this fits with apical dyskinesis, akinesis, with a global reduction in strain. Again, same thing here. Now just on this flat part, these are apical segments here. We have kind of certainly positive numbers here indicative of abnormal strain. So now for a couple coronary cases, 60-year-old male patient with known LAD disease. Here's his coronary CT scan. So again, the LAD coming down here. We have a significant area of kind of soft, little calcified areas here, followed by this severe area of plaque and stenosis, kind of the mid-LAD. You saw a couple of these images earlier. This is a CT perfusion study on the same patient. We see, kind of an area in this mid to apical anterior segment correlated with decreased perfusion on CT scan. So if we look at his 2D images here, again, the real-time 3D images here, we have the 4-chamber, 2-chamber, and apical long axis. His ejection fraction overall, we'd probably call this pretty well preserved. We don't see kind of a grossly focal wall motion abnormality. But we look at a strain here, again, the apical segments, the inferior segments, pretty well preserved. But this anterior septal segments, we have marked, we do have reduction of strain here, -9, -14, -13, and this kind of correlates with his CT perfusion. So if we kind of rotate this so they match up, anterior segment here, anterior septum, certainly consistent with his known coronary disease and perfusion defect here. Another case, again, 67-year-old male with LAD disease as well as an occluded, chronically occluded distal circumflex. Again, as 2D images, parasternal, again, preserved EF. We call this no systolic dysfunction. When we look at strain, here, again, the apical segments as well, but we have a segment, kind of this anterior lateral segment as well as a posterior segment, marked reduction in strain. And if we compare it to his prior CT perfusion, we do have an area of kind of perfusion defect in this anterior, possibly anterior lateral wall, consistent with his occluded circumflex artery here. Another case, 67-year-old female. She had a history of cancer. She was treated with doxorubicin many years ago. So again, someone that we're following up for cardiac dysfunction. Again, her 2D images. By any other measure, clinically, we call this normal systolic function, preserved EF, no real dysfunction. If you look at strain here, certainly not normal strain. Globally, there's reduced strain, apex mildly reduced, and then kind of the mid and basal segments, marked reduction in strain. And this has been a decrease from prior echoes that she's had before, so someone that we're serially following for strain pattern. And so again, someone that would say clinically they have a normal EF on echo by any other measure, but her systolic function is not normal. So a few cases to kind of go through, probably a lot of information, but kind of wanted to go through a general overview of what strain is, how do we measure it, how do we use it clinically, and kind of a few cases to correlate with other modalities. So questions, comments in case?
Yeah, so I had a question, and I was thinking that in Dr. Marwick's article, he said strain when there's damage or injury or problem with predicting in hypertensive patients that they're going to have problems, the strain is either stays the same or increases. And so an increase in strain, semantics would say that a -10 if that number goes to, say, +3, then that number increased. So that's an increase in strain. And so -19 to -14 is an increase in strain. It's a decrease in negative number, and so that's very confusing. And so we have to really be guarded in our semantics when we say strain increases. The negative number doesn't go from -14 to -19. It goes from -19 to -14. And so that can be confusing conceptually. And so you got to keep that straight in your mind, right?
Yeah, a lot of these studies, they'll mention, sometimes they don't even put the negative number in there. The ASC document, a lot of studies, you'll look at the absolute value of it, so they don't even worry about negative or positive numbers. They look at the absolute value, and they do mention semantics, maybe get away from saying, does it increase to positive numbers? You want to look for, is there, by semantics, a decrease in strain or increase in strain. A decrease in strain is obviously indicative of dysfunction, whether or not the number goes from -20 to -10 or from -20 to +3. So a lot of studies you may look at may have just an absolute value. So just keep that in mind when you're kind of looking at values and studies. There are, it can be confusing at times.
So we want to welcome Luke Russell to our group today, and we appreciate your coming. Beth Torres is also attending. This has been a very comprehensive review of strain. I'm not sure how many of our hospitals have strain. We'll have to check and see. I know Palms of Pasadena has strain. Memorial Hospital doesn't have strain. I don't know which other hospitals do. Do you have strain at Northside?
We do. I mean, we have GE and Philips machines. They're both capable of doing it. It's hit or miss. Currently, they're not routinely doing it.
Yeah.
But it is something that, like any other modality or any other thing, you need to kind of make it a routine like you guys have done here, do it on everybody. That way everyone's comfortable looking at it, getting images. But it's something we don't routinely do.
So it's really hard to integrate strain into your workflow. And like Nick says, what you've got to do is you've got to decide, this is important to us. Getting to the end of this road and understanding this is extremely important. It's important enough for us to train our techs, and then when they get really good, you saw how long Chrissy takes. It's like, a couple of seconds to the end, and maybe another minute or so, and she's got strain. And so then if we look at it on every study, then something starts correlating. And after a while, we get used to that, and we get used to using it. Now, we have a cardio-oncology clinic, so it's important to us there. That information hasn't been proven yet that strain is predictive of anthracycline or chemotherapy, chemotoxicity, and cardiotoxic damage. And so Dr. Marwick of Tasmania, he's in Hobart, he went back home from Cleveland Clinic, basically is in the progress of doing a large study called the SACAR study, which basically will prove that yes or no. So we're excited about that. We're excited about the hypertensive patients. We're excited about all the coronary disease patients that we see all the time. And then other patients, recent report with mitral regurgitation is interesting to us because we're always following people with mitral regurg, and we want to know, do they have LV dysfunction, and how can we detect it early when they have a valve that's repairable before they have significant LV dysfunction, or before they have LV dysfunction that will manifest itself post-op when you get rid of the ability for the ventricle to unload with the mitral regurgitation. And so all these things are very important. This is very important, and we have to make sure that our colleagues in our HCA hospitals realize that this is extremely useful. I'm going to be using it hopefully in the emergency room on people who present there if we can get a strain package at Memorial. And so I think it's extremely useful. It's helped us in correlating with myocardial perfusion imaging, and the correlation seems to be pretty good, doesn't it? So we have to get more data. And of course the artifacts are one of the things that gets in the way with myocardial perfusion imaging. So thank you so much for attending today. We have recorded this, and our producer, Dr. Tarek, will be posting this on cardiaccarecritique.com, and he usually posts them within a day or two. He deletes any names, so there's no HIPAA violation. And so I hope that you have an opportunity to go there if you want to refresh, because this is a lot of information all of a sudden. but it's a great summary, and we hope this can be used by our other HCA hospitals to introduce their technicians and physicians to strain. Thank you very much for attending. I appreciate that. And if Mary could just stay for a minute, I need to talk to her. Mary Daniels, can you speak to me? Yes.